Our knowledge and truth for a healthy living is a must. Here are the experts. Here are the facts. Here is what we testify to and speak. This is We Shop Talk.
Welcome to We Shop Talk 2025. I'm Dwight Eubanks, coming to you live from the Purple Door Salon, 321 Edgewood Avenue, Atlanta, Georgia, where we topic and address interesting conversations about healthcare in our community. It gives me great pleasure to introduce to you Dr. Akatobi, the CEO of Softcare Family Physicians. Dr. Akatobi, welcome.
Thank you so much, Dwight. It's a pleasure to be here again, the first episode for this new year, 2025. To all our audience out there, we wish you the very best of this new year and beyond. Last year, we hosted a couple of roundtable conversations involving prostate cancer, breast cancer. This year, we're kicking it off with obesity in America, and particularly focusing on Black America. And we have joining us today a esteemed panelists and some of our clients from Softcare Family Physicians who have had some successes with some of the treatments that they started to manage their weight condition, who are willing to share their stories. To my right is Dr. Ola Odugbeson, who is a consultant endocrinologist with North Endocrinology and Diabetes located in Lawrenceville. He's an accomplished endocrinologist trained in the United Kingdom in London and did his fellowship at Emory University. And he's a partner with that group and has been in practice a long time in Atlanta. Dr. Ola Odugbeson, we truly appreciate you making time to join us today to share your knowledge and wisdom on this very important topic that affects a lot of people in our community. Dr. Odugbeson.
Thank you. Thanks very much.
Thank you. And to my left is Ms. Kiana Lawson, who is through and through an Atlantan, born and bred, Spelman, and then Howard University. She's a physician assistant with Softcare Family Physicians, and she runs the weight management program of Softcare Family Physicians, where we have probably close to about 400 clients who are enrolled in that program now with different successes. Ms. Lawson, thank you so much. She's also the president, by the way, of the National Coalition of 100 Black Women, a Decatur chapter. So she has that hat, but she's not putting on that hat today. She has a physician assistant hat on as an internist. Ms. Lawson, thanks for joining us.
Thank you so much for having me.
And we have also with us today Mr. Stanley Scott, who is a client within Softcare Family Physicians, Mr. Gerald Goolsby, right behind me, and Mrs. Jobeth Goolsby. So Mr. Scott, if you just want to introduce yourself to our audience.
My name is Stanley Scott, and I've been a patient of Dr. Akatobi for a couple of years, I guess.
Yes, sir.
Mm-hmm. And I started the weight management, I guess, about a year ago.
Mm-hmm. Thank you, Mr. Scott. Mr. Goolsby?
I'm Jerry Goolsby. I'm a patient of Dr. Akatobi for over 30 years, and I started the program last April.
And Ms. Goolsby?
I'm Jobeth Goolsby, and I've been on the weight loss program also with my husband, and we're glad to be here.
Thank you so much. So what we're talking about today, focusing essentially is on obesity in Black America. So to really understand what obesity is, we're going to turn to a panel of experts to kind of help to lead that conversation. Obesity, without question, is a public health crisis in America today. And if you look at the numbers, over the last 40 years, in 1980, only 15% of Americans were obese. In 20 years later, in 1990, we had about 31% of Americans who were referred to as being obese. Right now in America, 42% of Americans are obese. I'm going to delve down a little bit into the numbers. But Dr. Odugbeson, what exactly is obesity?
So thanks very much. I think it's very simple. Obesity reflects a scenario where your weight is much higher than what would be normal for your height. So typically, the current definition is based on something called BMI, or body mass index, which is a way of looking at your height in relation to your weight. And the calculation would indicate that obesity would be a BMI of 30 or above. Severe obesity will be BMI of 40 or above. And then you have a category of what we call overweight, where, you're not obese yet, but you're not at normal weight. And most of those folks are somewhere between the BMI of 25 to 30. So it's a reflection of what your weight is in relation to what your height is, and whether, in fact, you are in the appropriate range.
And along those lines too, Dr. Dubeson, I know that there has been a lot of discussion as to the appropriateness of BMI in really using that as a tool to really make a diagnosis of obesity or overweight. And there are arguments for, there are arguments against. Where do you stand in that conversation?
Yeah, I think there's a lot of discussion right now as to whether we should be using just BMI as a reflection of being overweight or being obese. There's a lot of discussion about looking at body fat measurements as a reflection of your weight. And I think one of the classic things that we see, and we see this here in Atlanta, in the area that I'm in, there are certain ethnic groups where, in fact, when you look at their BMI, they're technically at normal weight. Mm-hmm. But when you talk to them and you say, what's happened to you, for example, says you moved to the United States 20 years ago. Well, I've gained 20 pounds, but you're still in, quote unquote, the normal BMI. So there's a lot of discussion about changing the definition of obesity, looking at maybe percent body fat or the average amount of skeletal muscle mass as a way of defining who is at risk. Because at the end of the day, all we're trying to do here is to say, all right, your weight puts you at risk for heart disease, for diabetes, for high blood pressure, for kidney disease, for certain forms of cancer. And it's not just about the number. It's about what is the risk associated with your current body weight.
Thank you so much. And along those lines, there is what they now call the Body Roundness Index, BRI, which looks like it's gaining some traction in terms of being able to define who is obese, who is overweight, and who is severely obese. Now, Ms. Lawson, I mean, what are the causes of obesity just in general, in terms of what we've seen, where even amongst children, 1 in 5 kids in America today are obese. Amongst adults, in general, 2 out of 5 Americans are obese. Why are we seeing this trend over the last 40 years?
That's a great question, Dr. Akintobi. The thing is, I look at, we have food deserts a lot in the Black community. We look at how we were raised. I think there's not enough programming within our community to help with how to eat nutrition, how to read nutrition labels. Sometimes it's due to not the income. You know, when you look at low income versus middle income versus people who have it, people who do not have it. If we look at our communities, we do not have great grocery stores. We know now that there's a lot of different things in these packagings that are not healthy for us. I think we need to have more education in the schools, and it starts at schools, it starts at home. It needs to be a community effect. The thing is, obesity is a chronic disease. If we do not get to that understanding that obesity is a chronic disease, how do we prevent the strokes, the heart attack? How do we prevent the sleep apneas, all of those things? Because at the end of the day, it's just like a domino effect. You know, we're overweight. Overweight causes these health conditions, and these health conditions cost money to treat. So how do we reduce having to treat these things? It starts, with how we eat.
Thank you so much, Ms. Lawson. And along those lines too, you find out that there are certain medications that can actually cause obesity. People that take steroids, for instance, or people that may have some other medical conditions, whether it's thyroid disease, that may also be at risk for having obesity. And there are some people that are genetically predisposed based on some genetics too, that may also be at risk for having heavy weight. And part of it too is really defining how the community defines some of those terminologies. So in the African American community, we might say, oh, she's big boned, or she's heavy set. And some of those things may be acceptable just based on definition. So, Dr. Dubeson, are there any other causes of obesity that you think?
So one of the things that we have to be careful about is not to assume that everybody that's obese is because of excessive caloric intake. Mm-hmm. There are conditions, as you rightly pointed out, where in fact the increase in body weight is due to a series of medical conditions. And one of the clues that might allow you to sort of start thinking about that is how quickly did that happen? Somebody who's been, relatively at ideal body weight, all of a sudden over a year gains 25 pounds or 30 pounds, and you say, wait a minute, that doesn't sound right. So that there is that clue. But there are conditions you mentioned, thyroid disease, underactive thyroid is one of the fundamental things that we have to rule out in anybody who comes in who is either overweight or obese. And I think most people get that checked out. There are rarer conditions. A classic one would be a condition called Cushing's syndrome, where in fact there's a tumor of the adrenal that produces excessive cortisol that leads to a substantial increase in body weight. And certain medications, you mentioned steroids, that's very classic. But one of the things that we now recognize is that, in fact, type 2 diabetes itself does predispose to being overweight or obese. So one of the things that we have to do is when we see somebody who is challenged by their weight is to make sure that it's not due to a medical condition or due to medications that they might be taking before we actually start the weight loss program.
Thank you so much. And we're going to bring in our other guests in just a minute, but I want us to look at some numbers because this also really drives the point home. Across America today, the total number of individuals who are obese is about 31, who are overweight is 31%. So 1 in 3, meaning that the body mass index as defined by Dr. Dubeso and Ms. Lawson is anywhere from 25 to 29, 31%. 42% are obese, meaning the BMI is more than 30, between 30 to 39. And close to 10% of Americans have severe obesity. These are the folks that often you might see on times or maybe on some TV programs with weights over 300, over 400, irrespective of height, where they really struggle. But if you look across the African American community, 59% of women are obese. 41% of men are obese. The question is, why is there a disparity where you see obesity, or even obesity specifically, higher amongst women compared to men? And that, irrespective of socioeconomic status or income, is the same for women across the board. Ms. Lawson, is there any explanation as to why you think that may be at this point?
Well, I'm a little biased because I'm a woman, right? And I think that women wear a lot of hats. So that could possibly be one of the reasons. We're the doctor, the lawyer, the Indian chief, the social worker, the friend, and so I think in America today, especially Black women, we wear a heavy load. And outside of what we discussed earlier when we talk about the food deserts, or like you say, outside of social economic status, I just think it's just a lot going on, outside of depression. There's a lot of different variables that can lead to weight outside of the predisposing health conditions. When we talk on everything else that's going on in society, we had patients come in because of what's going on in society that they're not eating right. They having eating disorders now. They having body dysmorphia. It's just a lot of different things that's going on. So I think for women, because we wear a lot of different hats, we got a lot going on, more so than men. Yes, men are providers, but women, beside a good man, what is a woman? We in behind, we on the side. Okay?
The side. Well said. And the other point too, which some scientists are looking at is women go through different changes in their lifestyle. Mm-hmm. They go through puberty. They have children. They are the ones that carry the children. And there's some weight that might be gained with that. And then they go through menopause. And because of those changes over time, there is no question that you might say that might be part of the explanation as to why.
Yeah. I think you raised it very, very well. I think there are three life events in women that men do not go through, although that may change. That leads to an increase in body weight, and you rightly pointed out the onset of menses actually increases the chances of being overweight. Pregnancy, and I say that might change because in fact there is research that's looking at men being able to carry a baby, and that's another program that we can talk about. And then of course menopause. So those three things, the effect of menstrual cycles, starting menstrual cycles, the effect of pregnancy, and the effect of menopause have clearly been shown to increase the chances of excess body weight in women compared to men.
Thank you so much. And Ms. Lawson, before we bring in our other guests, you run the South Dakota Family Physician Weight Management Program.
Yes.
One of the big, of course, questions that people have always talked about is making sure that whatever programs you develop, in terms of its cultural competence, its relevance, and meeting people where they are, understanding their nuances in a culturally competent environment. How have you been able to put all of that together in starting a program targeting obesity and looking at weight management? And once you're done with that, we'll then bring in our panelists after Dr. Dubeson has given us a history of the Ozempics of the world. How did you get to this point? Ms. Lawson.
Well, I know last year we came up with the idea of incorporating the weight management program, introducing semaglutide, whether it was the Ozempic or Wegovy. And at that time, we saw that we know there's a need in our community for it. And outside of course, ensuring that there were no pre-existing conditions that caused the weight, we wanted to make sure that we can introduce this medication within our community to our patient population that will allow them to see benefits, not just with A1Cs if they were diabetics, but also with their weight loss, with their numbers. We were noticing that with the program, upon starting, the program lasted 6 months and is still ongoing. But we noticed that a lot of patients with losing the weight, they were able to come off some of their medications, some of their diabetic medications, some of their blood pressure medications. So at the end of the day, losing the weight helped with reduction in medicines that one had to take. We also noticed that I would tell the patients it's not just about losing the weight, it's mental, it's spiritual. You have to work out as well, because at the end of the day, you have to look in the mirror. It starts with you, as accountability. So ensuring that they understanding that they're going to be held accountable. We're going to make sure that they have nutrition as a part of this process. So it's almost like a cake. I would tell we layer it like a cake. We have all the pieces of the layers of the cake to make the cake. So we have the exercise, we have the water intake, you have access to resources, you have nutritionists, you have access to us as providers, Dr. Akintobi and myself. And at the end of the day, we want you to have great results because it's about your health, not just about losing weight, because the medication is a tool to assist with losing weight. It is not the ultimate end.
Thank you so much, Ms. Lawson. Now, to that point, we know that amongst individuals who are obese, 56% will have high blood pressure. 25% of obese individuals will have diabetes. So at the end of the day, the data is clear that if one can lose between 5 to 15%, all those risk factors will decrease significantly. Risk factors for heart attack, risk factors for stroke, risk factors for cancer in some instances, like cancer of the ovaries in women, which we know that with obesity, that risk can increase. So we were extremely excited over the last 10, 20 years, Dr. Dubeson, when GLP-1s came into existence. GLP-1s, again, for our audience, called glucagon peptide-like substances or hormones. I'm going to have Dr. Dubeson talk to us exactly what that is. So if you hear Ozempic, that's what we're talking about. If you hear Wegovy, that's what we're talking about. If you hear Mounjaro or Zepbound, that's what we're talking about. What are these medications, and why is it such a big impact in the healthcare industry, knowing that obesity management in America today is a $200 billion industry? $200 million, Dr.
That's a lot of money.
Yes, sir.
So it's interesting because I think in the last couple of years, the public has become aware of Ozempic. But in fact, these therapies have been around for 20 years. Okay. The first one was a drug called exenatide. Now, the background of this is this. In the gastrointestinal system, so within our small intestine, there's a series of hormones that are produced when you eat. And one of those hormones is GLP-1, glucagon-like peptide 1. The minute you put food in your mouth, your intestine starts to produce this glucagon-like peptide 1. What does that hormone do? It does four things. The first thing it does is it goes to the brain and tells the brain, hey, he's eating, reduce the appetite, make him more full. The second thing it does is it tells the brain, hey, you shouldn't really be hungry anymore. So those two things would encourage you to eat less. And then two additional things, which is why it is used in diabetes, it is able to increase insulin production. When you eat, your blood glucose naturally goes up, but GLP-1, which is naturally produced, is able to limit how high that blood glucose levels go up and is able to bring your blood glucose levels down. And then finally, the fourth thing it does, it counteracts a hormone called glucagon, which is a hormone that tends to raise your blood glucose. So those four things have always been known to be produced by this hormone called GLP-1, which is naturally produced by every single individual. The challenge was that patients who had diabetes had a deficiency of this hormone. So there was a lot of research to say, all right, how can we get this to patients with diabetes? And it started off 20 years ago by some guy looking at the saliva of a particular type of lizard called, does anybody remember what the lizard is called? The Gecko lizard. And he looked at the saliva of that lizard and found that, in fact, within that saliva was a compound that was very similar to the GLP-1 that's produced naturally in the gastrointestinal system. So the very first prototype of GLP-1 therapy was produced in 2005. It was a drug called exenatide. Some of you may remember a drug called Byetta, right?
Yes,
We used to use that. That was a GLP-1. Now, fast forward 20 years later on, there has been modifications of this drug. And we're now at a stage now that we have drugs like semaglutide, which is Ozempic for diabetes, Wegovy if you don't have diabetes, tirzepatide, which is Mounjaro if you have diabetes, Zepbound if you don't have diabetes. These drugs still basically do those four things. They reduce appetite, they enhance satiety, they make food stay in your stomach for longer. So there's a decrease of gastric emptying. You feel full for longer. And on top of that, they're able to raise insulin when appropriate for the patient who has diabetes to limit how high their blood glucose levels down. Now, one of the things that's interesting right now, you point out the fact that this is a huge industry financially. So pharmaceutical companies are very interested in making money. Okay, I don't think we should forget that. And I don't think that's a bad thing. Yes. I think when you encourage people and say, look, if you do this, if you can come up with a drug that is able to allow people to lose 20% of body weight, you're going to make $5 billion a year. So there's an incentive for them to keep looking. And one of the things that you may find in the next year or so, there's now a higher level of therapy. Now, GLP-1 basically is a drug that only has one type of hormone, GLP-1. Then you had a drug like Mounjaro or Zepbound, which is actually two drugs, GLP-1 and something called GIP. The next category is a drug called retatrutide, which actually has three factors, GLP-1, GIP, and the glucagon receptor agonist. So, and the incentive, like you pointed out, is that in fact, this is a huge industry. And if you're able to bring out a drug that is effective, that has limited amount of side effects, you're going to be able to make money. So we're going to see over the next several years even better weight loss therapies compared to the one that we currently have.
Thank you so much, Dr. Dubes. And that history is so very important. For individuals out there to understand that Ozempic did not happen overnight, that Mounjaro did not happen overnight. Lots of research for 20, 25 years. The same companies that started using insulin, the Novo Nordisk of the world, and the Eli Lillys of the world are the ones that are leading this research. And there's no question we've seen results. And so to put numbers to it now for our audience, Ozempic and Wegovy, like Dr. Dubes and Ms. Lawson alluded to, will reduce weight by 15%. So if you weigh 200 pounds, you can lose 30 pounds with Ozempic or Wegovy over a 6-month period, 48 weeks to be precise. Mounjaro and Zepbound, like we talked about, is 2 medications in one. essentially, just to simplify it. That will reduce the weight by about 18%. The new medication Dr. Dubeson mentioned that is going to be out in 2026, 2027, will reduce weight by about 20 to 25% of one's body weight. So can you imagine if you weigh 200 pounds, on this medication, you can lose 50 pounds, which is 25% of your body weight over a 48-week period. And we're only just beginning to scratch the surface. Mr. Scott, what's your story, sir?
Well, I've been overweight, I guess, most of my adult life anyway. But I remember once upon a time, I used to weigh over 300 pounds. And then I think when I come to you all, I might have been weighing 282, and now I weigh 232. I'm trying to get down to at least to 200. I'm trying. Yeah. But my wife said I'm getting too little.
I was going to come and talk about that in just a little bit. How do you deal with that? Ms. Goolsbee, what's your story, ma'am?
My story is it has brought down my A1C. I've lost weight. I was over 200 pounds. And I've lost about 60 pounds also. I'm trying to keep up with my husband.
Very nice.
But it has been a very good tool because I have an autoimmune disease also. Mm-hmm. And my doctor on that end has told me, please try to stay on this medication because he has taken me off of one of the medications for the autoimmune disease. Mm-hmm. And I'm still on one, but I'm working really hard trying to get off of everything. Mm. And this has been a great tool to use for weight loss and my blood glucose and the autoimmune. And I can just see a difference in my whole body. I don't hurt. My back doesn't hurt anymore. I'm reading more labels. I'm trying to enhance my body with more protein, water, and it's helping. It's helping.
It's amazing that you say the word, Ms. Goolsbee, because these medications affect the center in the brain about appetite and feeling full. You may also not get the urge to want to drink water.
Right. And
that's extremely very important. We're going to come and talk about that a little bit more. But Ms. Lawson, you have about 400 patients now on GLP-1s. What have you seen in terms of tolerability? Is this a medication for everybody, diabetic or overweight? Because by the way, the FDA approves this class of medications for anybody whose body mass index is above 30. So if you're obese, you qualify to use this medication. Or if you're overweight, if your body mass index is between 25 to 29, and you have any other cardiovascular risk factors, whether it's high blood pressure, sleep apnea has been approved now, diabetes, overweight plus any other of those other medical conditions will qualify you to use this medication. Different conversation about what insurance companies are covering. Right, yeah. We're going to come and talk about that. For Ms. Lawson, what has been your experience? What do people notice when they start? Are there side effects? Are there things to look out for in terms of tolerability? And how have you been able to structure a program where you're able to see these patients in short term to see how they're doing? And why is that important?
Thank you. That's a packed. Let me unpack the question, okay? So with the program, it's designed for patients to come every 2 weeks and every 4 weeks because with the medication or with semaglutide, we go up every 4 weeks. We go up on the dose and we see the maximum benefit at the highest dose. What I've seen since we started the program and we talk about side effects, I've mostly seen a lot of constipation. I see constipation, I see a lot of diarrhea. Those are the top two. But with that, I make sure that the patients are increasing their water intake because a lot of times the patients are not drinking enough water, and that's key. Minimum at least 64 ounces if you're not doing half your body weight. Along with, I ensure that if they do some Metamucil or I have them do some smooth move tea, they like that. They say that works because at the end of the day, the weight loss is going to outweigh the constipation with them, okay, with the patient. And so, but the thing is they have to have the bowels moving. So we need the bowels to move, so you gotta drink the water. But I have seen some bouts of depression in some patients. And so I'm trying to kind of work through that. I haven't seen it in a lot of patients, but I've seen some depression. I've also seen some body dysmorphia where they have lost the weight. It is very obvious that they lost the weight. They lost over 30 pounds. However, when they look in the mirror, they still see themselves as the same. And so we are trying trying to unpack that. And so I usually, with those patients, I send them to therapy so that we can kind of dive deeper into where that stuff stems from. But overall, it's a great medicine. I notice when patients come back, they're excited to go to the next level. However, the reason that they're coming back on an every 4-week basis is because we want to make sure that there are no side effects where things are happening, such as they're falling out, they're fainting because they're not eating. Well, I don't want to eat. I don't want to eat. I just want to, I'm good. But they're not good because you're not eating. The body has nothing to fuel itself, and then that's what's happening. The blood pressures are dropping, and the glucose is dropping, and we definitely don't want those. So everyone understands the side effects or the adverse effects that can happen while taking the medication. That's important to know, especially before you start taking anything. I think it's a great medicine because, like you said, we see the results with the patients when they come in. They're more agile, they're more happy, they're moving around. They say, oh, I didn't know, I really don't need that no pain that's for my back now because, I lost this weight. Thank you. Yeah, because I lost the key. Okay. But with that being said, I'm very excited about the program. The patients are, once they get to the max dose, then I say, you got it, girl. You got it, Mr. X, because you know what to do. It's not just the medicine doing the work. You have to do your part too. You have to exercise, okay? You have to drink your water. You have to eat right. If you eat a lot of carbs, what's going to happen? Let's make it make sense, okay? So I hold the patients accountable, and I think we're doing a great job.
Yes, you are, Ms. Lawson. When you have over 400 patients who have success stories to tell, there's no question, there's a lot. And I know Dr. Odueson will have numbers to share with us too. But part of it too, oftentimes, again, as a community, is husbands and wives that carry each other along. We have Mrs. Goldsby and Mr. Goldsby here. We've had patients in our practice where the wife says, enough, you've lost enough. Or they come in and say, he's not eating anymore. And they worry. And you have to deal with those things. Or some people really lose weight and they don't like what they see. Like Ms. Lawson kind of talked about. We have to mentally prepare folks for that. That when wives come, we say, okay, maybe you don't need to go past medium dose and just stay right there. Because your wife is concerned that you're not eating anymore, or that you're not taking the necessary precautions. We've had some instances where some people's blood pressure medications had to be reduced. And we're going to talk about that in just a minute. But Dr. Odueson, to you, sir, what has been the story in your practice? Because as an endocrinologist, you deal with this every single day.
Right. This has been just a tremendously helpful for us, not just in the setting of diabetes, but in patients who have other comorbidities related to obesity. One of the things that we need to be really aware of is that when you are obese, not only are you high risk for diabetes, you're high risk for cardiovascular disease, which means heart attack and stroke. You're high risk for kidney disease because most folks eventually have hypertension, so you might end up with chronic kidney disease. And you're also high risk for certain forms of cancer, from genitourinary cancer to gastrointestinal cancer. And one of the very, very interesting things that has come out in the last couple of years has been the recognition that weight loss is so effective for all of these conditions: cardiovascular disease, kidney disease, heart failure, sleep apnea, certain forms of cancer have all been dramatically reduced by being able to achieve weight loss. But as Ms. Lawson rightly pointed out, we have to be aware that there are patients who may have side effects and who may not be able to take the medication. Fundamentally, there are two contraindications who should not be started on this drug. Number one, somebody who either has a personal history or a family history of a very rare form of thyroid cancer called medullary thyroid cancer. I do thyroid cancer work. Maybe I'll see one patient a year. So it's relatively rare. It's relatively uncommon. It's important to recognize the drug does not cause thyroid cancer. All we're saying is that if you have a family history of these very rare form of thyroid cancer, then we don't want you to take the drug. So that's one thing that most people need to be aware of. The second thing, and it's not a contraindication, the second thing is something called pancreatitis. Pancreatitis is a condition in which you develop sudden onset of abdominal pain, nausea, vomiting, usually a lot of back pain. It actually is more common in people with diabetes, but we have seen that it's more common if you're on GLP-1 therapy. So that would be another thing that we would say, all right, if you have that, perhaps we have to reconsider whether we want to use this drug. Side effect profile, I think Ms. Lawson is right. I think you will find that the vast majority of people tolerate it. In our experience, we find that about 5 to 10% of patients have side effects that makes it impossible for them to stay on the drug. Most of those side effects are going to be gastrointestinal: nausea, vomiting, diarrhea, constipation. Sometimes if you titrate the drug a little bit slower, you can get more people on it. But there is no doubt that you're going to have a small percentage of people who are not going to be able to take the GLP-1 category of drugs.
And thank you very much, Ms. Lawson and Dr. Dugbeson. And the data out there actually shows that maybe up to 40% of people over time may discontinue the medication for one reason or the other, but the vast majority have good stories to tell. Mr. and Mrs. Goldsby, having a couple, together, how has that been for both of you? Was it because one started before the other and you love the results that you saw? Or how did we get to this point? And how have you been able to encourage each other?
We basically started about the same time, and that was a blessing right there. And and we worked together, and I said, I don't want to eat anymore. He said, you got to eat a little bit more. And I said, okay, drink some water. I said, you got to drink more water. Okay, I drink more water. And we're just encouraging each other where we see the lack of each other. We try to fill that in.
And how have people been towards both of you? Family, friends, comments?
Lots of comments.
What kind of comments, Mr. Goldsby?
It's like people say, you look younger.
That's good. That's very good.
Every day someone says that you look so good and you look much younger. My pastor's wife says, she says, you're like Benjamin Button. You're
AJ Button.
That's great.
Okay.
That is good.
she's getting better. She's getting there. It's been great to see that people are recognizing. To me, I'm not seeing it, but everybody else sees the weight loss. And so being able to come off of my diabetes medication, no more metformin. I was at Kiana's office and I was lying here and they took my blood pressure and it was dropping, so you had to reduce my medication for high blood pressure. And no longer sleep apnea. I got tested and no longer need sleep apnea machines to sleep. So it's been a lot of benefits from having been on the program.
And
It's good to have a partner, and if you can, and to encourage each other.
Yeah.
Sometimes when I'm not feeling something and he says, okay, you got to do this. And I'll tell him, you got to do this. It's like I told him, you got to buy new clothes. So, I always try
Just maintain I couldn't do that. Spending thousands of dollars for just bought and I'm altered again. It's been quite amazing.
Well, that's a good problem.
Yes.
Because
The Salvation
it's a
Army
good
would love
problem to have because
It's in Canada, certainly.
Mr. Scott, how has that been for you in terms of the perception, how people have related to you, talked to you? I know Miss Scott is also here on the set here somewhere today. How has that been? How has the journey been? And what satisfaction have you derived to this point?
It's been good because more people will recognize me losing weight than I do. Like my son and all saying, you losing weight, because I never told nobody I was doing this medication for a while, But I've been having good things. That I have a lady who I've been dealing with 20 years do operation for me. And she came to the house about 3 weeks ago to take all my clothes and then get on operated. Yeah. And she was telling me that since she saw me last, I had lost 7, 8 pounds.
Inches.
7, 8 inches in my waist, So she took some, and these pants probably real old, but I paid good money for them.
Just want to let it go.
that's good.
Exactly, there's some pain and working on the leg. So it's been good for me.
So this is the reality, and it's so good to hear comments like this. But let's be clear. Wegovy, Ozempic, Zebound, and Mounjaro, they do more than weight loss. Ms. Lawson and Dr. Dueson mentioned that this is the most important piece why I think, again, for our community, we need to get as many individuals who qualify to be on this medication. The relative risk reduction, meaning the likelihood of one having a heart attack or stroke, is reduced, Dr. Dueson and Ms. Lawson, 20% reduction. The risk for having a heart attack or stroke, meaning if you're taking this medication, the likelihood that you're going to have heart attack or stroke relatively is reduced by 20%. Those are numbers we've not heard of on any medication in the history of the pharmaceutical industry. Not one. Not even the statins will do that, which is for cholesterol. So that if we can identify more individuals who qualify to be on this medication, how do we make it available, Dr. Dubé from Ms. Lawson? How?
So this is
because the medications are not cheap.
Right.
Yeah.
And because not everybody has health insurance.
Right.
How do we deal with that?
So this is a moving target. I remember that when GLP-1 therapies first came into being, it was only for people with diabetes. Then when the newer generation of GLP-1s came on board, it was not covered for anybody who just wanted to use it for weight loss if they didn't have diabetes. Now, that has changed. What you're beginning to see now is more and more plans. And let's just be really careful about insurance companies and coverage. A lot of times what we found is that the decision about coverage is actually made by the employer, who then instructs the insurance company and says, for us, yes, this is Blue Cross Blue Shield, PPO, but we're not covering weight loss medications. So I think it's important to clarify that. But it has begun to change. We're beginning to see more and more plans cover this therapy. So two strategies here, and there are two categories of patients. Number one, patients with diabetes. Generally now, if you have diabetes, 99% of the time, you're going to get one of the GLP-1 therapies covered, and that will be either Ozempic or Mounjaro. So you're going to get that. So diabetes, you're not going to have too many problems. The challenge is somebody who doesn't have diabetes, who is obese, who needs Wegovy or Zepbound or some of the newer models that are going to come. I think you've just got to be very proactive. I think it's important for those who have any direct access to policy to continue to lobby that weight loss medications should be offered just the way medications for hypertension, diabetes, high cholesterol is offered on insurance plans. I think we've gone away in endocrinology now. We look at obesity the same way we look at hypertension, diabetes, high cholesterol, heart disease, and kidney disease. We look at it like that because obesity actually leads to a whole host of problems that eventually is very expensive. So to go back to your question, coverage is still tough if you don't have diabetes, but it is improving. And we're beginning to see medical associations, lay associations continuing to lobby employers and insurance companies to get more of them to put the weight loss versions of these drugs on their formulary.
And to that point, in 2024, 48% of insurance companies covered the Ozempics of the world, the GLP-1s, 48%. That number we know is going to increase significantly. But then if you go across to Canada or you go across to Mexico, these medications are just a fraction of the price of the United States. I know of patients that travel to Costa Rica to go get a 6-month supply of Ozempic. Even with the cost of their flights and accommodation, it was still cheaper.
Absolutely.
Than getting it in the US. So these are conversations that are ongoing that we need to have to open up doors and to keep asking the question why and what needs to be done to make sure that a medication that can impact people's lives positively is not only for a select few.
So if you're out there and you have access to your congressperson, you have access to influencers that can pressure the pharmaceutical and the insurance industries, go ahead and do that, because it is important. It's not just physicians and patients who should be lobbying for this. Everybody should lobby for this to increase access to this very, very effective and very important medication.
They will, if you pressure them enough, they'll make it happen. They will create bills, policies, and make a change, because if we don't do anything now, how can we improve our health? If we know obesity is a problem, obesity is a chronic disease, how do we make our health, or create an environment where our health is number one, where we don't have to go outside of the United States to get medicine that should be easily accessible to us. And last year, there was an analytic company called Purple Lab that stated that 85% of semaglutide was dispensed to Caucasians. So that shows you there's barriers, racial barriers, and there's inequity. And so we have to come together to try to solve this problem.
Now that you heard the facts, apply the knowledge. Contact your doctor or healthcare specialist. Scan the QR code to provide more information on today's talk. See you on the next We Shop Talk.